Everybody, my name is Natalia Martinez. I would like to welcome to the fourth online Shawn Elbow School that the Junior Committee has organized. Today we have the honor to be here with Dr. Shawn and Dr. Davide Blonna, who will teach us about airborne instability. And I would really like to present you the attendees that we have today. We have Patrick Carroll from Ireland, Ana Alfonso from Spain, Neil Kircherson from the Netherlands, Sebastian Lapin from Germany, and Pierre-Emmanuel Chamas from France. So welcome everybody. I think we can start whenever you want.
To start?
Yeah, by all means, go ahead, Davide. Greetings to everyone.
Okay. I will share my screen. So I've selected for you an acute trauma case. I know that Shawn O'Driscoll now it's more focused on chronic case, so I've decided to select one of my acute case. Can you see my presentation? Okay, so I try to organize this case presentation a little bit interactive. So, but if you have any more questions, just stop me. Shawn, if you want to interact with the five, just ask your question, and I will ask other questions to you as well. So this is a 55-year-old male that had a trauma, not a very high energy trauma, that presented to our ER with an elbow pain. As you can see, the elbow was not very painful. The VAS score for pain was 3 out of 10. It was otherwise in a good medical condition. I did not have the chance to see the patient in the ER, but I pick up this data from the online notes. The range of motion was quite good. He had some pain during range of motion, especially in the medial part of the elbow. He had some swelling, but not too much, no hematoma, no clear dislocation, and the elbow stability was not tested at the time he presented to the ER. So let's start with Patrick. What to do, Patrick? What will you do in this case? Would you ask more questions? Would you ask for some image studies?
Yeah, so I take a full history and examination. I'd find out his hand dominance, his occupation, has he ever injured this elbow before, and exactly where his pain is, if it's just medially or elsewhere, laterally or posteriorly, and if there's any other associated injury in the wrist, the forearm, or the shoulder. I'd examine the patient and looking for bruising and swelling and the range of movement, as you've said. And then I would do imaging. So I'd start with a plain film X-ray of AP and lateral of the elbow joint.
Good. So he had no prior history of other trauma on the elbow. And I don't remember what job he did at the time, but no particular type of job. So we asked for a standard elbow X-ray, and this is the X-ray. So Anna, what do you think? What do you see in this X-ray?
Okay, we can see here a lateral and an AP view of the elbow, and the AP view, I cannot see anything acute there. To me, the joint looks reduced to me, no signs of fracture. But in the lateral side, in the lateral plane, I can see kind of probably a chronic thing going on there. I'm trying to think, maybe it's from the coronoid, but I'm not sure. Yeah, but it looks to me like a chronic, yeah, over there, yeah. It looks to me like a chronic lesion there.
But he had no history of other trauma.
Yeah, so it could be a little bony spore then, like part of ligament tear, but I cannot see it perfectly on the AP view, so I'm not sure where is it from. So I would probably ask for more imaging if after 10 days or so it keeps with the bruising and swelling and not feeling good with his elbow. That's what I would do.
So you will treat this patient conservatively right now and to see him like
Yeah,
follow-up?
I will
Okay.
I will ask him to wear a collar and cuff, or maybe collar and cuff, and to rest, no sports, and
Okay.
then reevaluate on clinic, in 10 days or so. That's what I will do, and prevent him from doing any sports or any hard job.
Okay.
Yeah.
I thought that was an acute coronoid fracture, to be honest with you, but also because he had no history of other trauma. So for me, when I see this strange area here, I will consider that's an acute coronoid fracture until proved differently. That's my experience. Patient that had, at least in my experience, coronoid fracture without dislocation, they usually don't have a huge amount of pain. Okay, they have some pain during range of motion, but usually they don't have a huge amount of pain. And here also, as you told in the AP view, there is no something specific that I want to comment on, but there is probably something here, maybe a little piece of bone, but I'm agree with you, it's very tough to be sure about this small area here. What you can see here, it's also some swelling in the soft tissue in the medial part of the elbow. But again, of course, it's just an X-ray, so it's quite difficult to say something more specific about the swelling. But I think that there is some swelling here in the medial part of the elbow. So to me, this was an almost isolated coronary fracture. So Nick, what do you think? Can you classify this coronary fracture? Or you think that it's impossible to classify this fracture just using a lateral AP view?
I don't think you can make a proper judgment with the X-ray. I think I would make a CT scan.
Okay. So I'm agree with you, but what about, just to comment on Regan-Murray classification, are you able to at least to say something about that? Do you think it's more like a tip? It's more like a type 3 or probably a type 2, something in between?
I think in
completely
between,
agree
type
with
2.
you. Type 2. Okay.
Yeah.
So Pierre, what do you think now? I mean, I was pretty convinced that this was an acute coronary fracture. So should we proceed with a conservative treatment or surgical treatment, or we need more imaging studies?
I had a concern about the AP view. I was wondering if there were fracture on the sublime tubercle because there was a very slight narrowing of the space joint, of the joint space, I'm sorry. And so I was wondering, there was a small secondary line of fracture reaching the sublime tubercle. So I was, before considering the treatment, I was wondering if a CT scan could be of use. Yes, that's the one.
So, there are a lot of different second level studies that we can ask for this type of patient. And but I agree with you that normally, I mean, of course, you can ask for a fluoroscopy, an MRI, an ultrasound, but usually, at least in our environment, we ask for a CT scan in virtually all the coronoid cases. I mean, all the patients that we suspect there is a coronary fracture in my hospital, I suggest to ask for a CT scan. Okay, this is something I've learned from my own mistakes. Of course, if you don't have a good X-ray imaging, you can ask for a better X-ray, but usually it's I think it's much faster to go for a CT scan. However, in this case, we ask for a new X-ray in extension. Because what I've learned from my experience, especially in a subtle type of instability, it's the X-ray and CT scan in extension give you a much better feeling of how unstable is the elbow. You can see here now the X-ray in almost full extension. And Sebastian, what do you think now? Can you see something different from comparing to the X-ray at 90-degree of flexion?
So yeah, I think when you look at the ulnar, a little bit more ulnar sidely, you can definitely see more clearly right there, exactly, the fracture. So I think to me it looks a little bit bigger than what it looked like when we saw it before in the standard AP view.
Okay, good. I agree with you. So this simple X-ray gives us much more information than the X-ray of 90-degree. You see, it's not probably just the tip of coronary fracture, but it's an anteromedial coronary fracture. And that it's a much worse pathology comparing to the tip coronary fracture. So this is going to be the CT scan, because of course, especially after these X-ray, we ask for a CT scan. Again, any suggestion about how to do the CT scan? You know, you can do the CT scan like in this position, but if the patient allowed to do that, you can do the X-ray, the CT scan in this position, so with the elbow in extension. Try to remember that usually the elbow it's more unstable in extension than in flexion. So if you want to if you want to have a more sensitive study, I think that you should ask for a CT scan in extension. So remember that. So Pierre, the CT scan is up to you. What do you see in the CT scan?
So it's only the sagittal view. Maybe an axial view would be of interest to grade the.
It will come later. Just
okay.
now, start with the sagittal view.
So at first, what we can see for the very pointy part of the coronoid process is that it's rather kind of a type 1, according to Regan and Morey. But we can see clearly that it's extending in the medial part of the ulna. So maybe we could use rather the O'Driscoll classification to include the injury of the insertion of the medial collateral ligament. Yes. So right there we can see that it's kind of a type 3, because all of the coronoid process from the radial part to the most medial part is fractured with a quite a big bony part. So I can tell that the medial collateral ligament is injured in this kind of injury.
Yes, I should agree with you, but I think it's probably more important than classification now. It's to recognize that this is a highly comminuted coronoid fracture, because I mean, if you want to fix this coronoid, it's not going to be easy. Okay, but I agree with you that probably there is a lesion of the MCL, even if probably the sublime tubercle is not completely affected by the fracture, because according to my understanding, this is the tubercle. So probably the fracture line is anterior to the tubercle.
Okay.
What is clear to me that here there should be the posterior part, the posterior bundle of the MCL that probably, I mean, not probably for sure is torn. Otherwise, it's impossible to open up this joint here without a complete lesion of the posterior bundle of the MCL. And again, here in the coronal view, you can see the highly comminuted coronoid fracture. I think no more information from the coronal view. This is the 3D that it's highlight. I think the same things that we have just comment using the other views. Again, you see here there is an open space here that should remind you that here there is a lesion of the posterior bundle of the MCL.
Davide, may I add a comment here on that CT?
Of course.
So a critical part, if you can go, yeah. So a critical part of the anteromedial fractures that are due to posteromedial rotatory instability is that the shape of the fracture is concave into the anteromedial facet. And if you let your video play, you'll see on the top left image of Dr. Blonna's video, you see how the trochlea went right into and through the coronoid and sheared it off. And on the bottom left picture, you can see how the coronoid fragments are being pushed forward by the medial trochlea. And on this CT image, you see that the shape of that medial trochlea, which is, you know, a convex shape to it at the bottom, is driving through and into the coronoid. And it's the shape right there. We're seeing it right now. The shape of the trochlea is what creates the shape of the fracture line anteriorly. Yeah, so maybe, I guess I can annotate, can't I? So right in here, right in this area right here is where the shape of the fracture line is being created by the shape of the trochlea. So sometimes you'll see a fracture that's convex there that goes over into the anteromedial, into the sublime tubercle. That's not a posteromedial rotatory injury with an anteromedial facet fracture. Yes, the anteromedial facet got fractured, but that was a tip fracture from posterolateral rotatory instability that also extended over further, probably because after the patient falls, you can continue to break some more fragments. They don't all break instantaneously at the same time necessarily. So really important distinction. And the best way to discern that is look right in the ulna there, take away the humerus on the CT scan and look at that view. And you should see a yeah, let's just freeze that right there. That's a good one. I don't know if you can freeze that right there, Davide. Is that possible? Right where at the beginning?
Beginning here?
Yeah, way back at the beginning, yeah. Right there, perfect. Okay, so if you now subtract the humerus on the CT scan, and every one of these I think you should do, then right in here, you'll see the shape of the fracture. You see that where I've drawn that? And that's the key feature. If you see something that looks somewhat like, here, I'll draw it with a different, with a finer line and maybe I don't know, maybe a black line perhaps. If you see a fracture that looks kind of like this, that's not a posteromedial rotatory injury. And I mention that because this is not very clearly understood by many. And in the literature, the illustrations that have been used that have referred to the O'Driscoll classification are not the original illustrations 99% of the time. And they show a convex pattern instead of a concave pattern. And that's actually, you know, something important to distinguish. Thanks, Davide.
Thank you, Shawn, for your clarification. So in summary, okay, this is a comminuted coronoid fracture. So Anna, what do you think? How would you classify now this coronoid fracture according to what Shawn has just told us?
I think it's an anterior medial fracture. I think it's a very complex fracture and very hard to fix this. I was just as Dr. Dilko was explaining to us, I was thinking about some bone graft you could use to fix this, because I don't know if you can fit a plate or screws in there. I was thinking about it, but to me, it's an anterior medial facet.
Which subtype? It's subtype 1, 2, or subtype 3?
To me, the subtype maybe 2, anterior medial facet plus the tip. Yeah, that's what I was thinking.
You have here
because to me the sublime tubercle is okay. To me, the sublime tubercle is in place, as we can
Shawn,
see here in this view.
Yes, exactly correct.
Good. Thank you. So this is a highly comminuted coronoid fracture. There is an incongruent joint, a lesion of the posterior bundle of the MCL. You see here, I put some drawing on the CT scan. So as Shawn already told us, this is can be classified as an acute posteromedial elbow instability. In order to try to highlight the features of the posteromedial elbow instability, I've used this kind of tool. Sorry, there's some sound. You see, usually it's a varus trauma on the elbow. And during the varus trauma, you have a fracture on the anteromedial part of the coronoid. This part here, this area here, as we have just seen in the CT scan. But usually it's not enough. What you have also to consider, it's a lesion of the LCL complex. But again, it's not enough. Usually what you have an opening of this space here, of this joints line on the posterior part of the medial side of the elbow. And so you have to have a lesion of the posterior bundle of the MCL. It's important to recognize all these structures, because in order to have a stable elbow after your surgery, you need to address, at least in the majority of the cases, all these three pathologies. So the coronary fracture, the LCL lesion, and the MCL lesion. So, Patrick, what do you think? Now that you have the CT scan, you have all the information you need, what would you prefer for this patient, a conservative treatment or a surgical treatment?
Yeah, so this is an unstable injury in a young 50-year-old gentleman. So I would explain to the patient that that surgical management is what I would recommend. Developing in the short term and to get back to function. Regarding the surgery itself, I would appropriately mark and consent the patient and bring him to theatre and do fluoroscopic imaging. And I would do this before he has any muscle relaxant before going to sleep, and then check the valgus varus stresses, and just to get the exact degree that he dislocates in extension. And then I would go on to do a 2-incision approach in the supine position, both lateral and then medial, stabilizing the lateral collateral ligament. And then it's a difficult case. I haven't performed this myself on the medial side, but I would do, I suppose, an FCU interval between the two heads approach, or
Yes, I think there is some problem with your connection, or maybe it's my connection, I don't know. Anyway, I mean, all the things that you told us, it's correct. Any of you think that the conservative treatment can be an option for this male? Shawn, what do you think?
I wrote it as a point for discussion if it didn't come up. So there is an option for conservative treatment, but we have to define it very carefully. Antonio Ferruria from Madrid, who was a fellow with us in 2008, has published on this. He's documented very clearly that with these anteromedial facet fractures, that in at least in the cases that he has treated, that you can treat them successfully by putting them in a cast for 3 weeks and then a removable splint, preventing any varus gravitational stress on the elbow throughout that time period. It's critical to document on a CT scan that the joint is congruent. So this one is not. And therefore, I think, if I understand his indications correctly, he would not treat this one conservatively. I wouldn't. I would operate on it. But I would say that it remains to be clarified exactly who can be treated in a cast and who needs to be treated surgically. It is really important to not ignore them and not just do nothing for them. So conservative treatment does not mean doing nothing. It means either you operate or you put them in a cast and document that it's still anatomically reduced. My sense is that because these, when they do go wrong, because these are so devastating and typically end up with an elbow replacement, that I don't think it's wise to take a chance on this not turning out well. If you can document that it is reduced and congruent, it'll probably be okay in a cast, but we have to clarify that further with time. What are your thoughts, Davide?
I mean, my thoughts are very similar to yours. What I still don't know, it's the case where you ask for a CT scan. In the CT scan, maybe the CT scan was performed with the elbow was flexed 90 degrees. So maybe was congruent at the time of the CT scan, but that doesn't mean that the elbow is stable. In this case, the CT scan was performed with elbow was in extension, almost full extension. So I think that from this patient, I've learned that all the time where I suspect a posteromedial instability, I ask for a CT scan in extension. So this is something that I've learned from this particular patient here, because the X-ray was almost normal. There were no sign of clear instability in after the simple X-ray. So what should we repair? As I told you, since we have recognized this is a posteromedial elbow instability, we have to repair everything. We have to repair MCL, LCL, and coronoid. Of course, it's not easy to fix this type of coronoid fracture. So I think that if you are going to treat this type of patient, you have to be ready with everything, with screws, with pins, and with plate. Which surgical approach? Nick, what do you think? Single posterior approach or one medial and one lateral approach?
I haven't done this surgery myself.
There is no right answer.
No, I think I would go for 2 separate incisions. I think if you go from posteriorly, then yeah, you have to make huge skin flaps to go both ways.
Agree with you. How to fix the coronoid? Sebastian.
I think, as you said, you have to be prepared for everything. It might be a good idea to try with screws first, if the fragments do relocate with the screws and they can grab onto them. But if it doesn't work, you would have to maybe use K-wires or just see what works, basically. So just be prepared for everything.
Good. How to repair the ligaments? What do you think?
Well, I would try to, well, of course, depending on how they are torn, either to try to refixate them or just to basically suture them. Maybe laterally you can do an LUCL reconstruction. But I think especially medially, it would make sense to try to refixate that ligaments.
I think it's very easy to repair it with anchors. Usually I use metallic anchors. It's very straightforward procedure. And in all the OR, there are anchors that are used for shoulder. So you can just use some of them. But I will show you the video later on. So this is the patient under anesthesia. You see it's very grossly unstable elbow. It was unstable also in varus and internal rotation of the forearm. This is something that can be seen also just in this type of fracture dislocation. You can see here the lesion of the posterior bundle of the MCL. And by retensioning the posterior bundle of the MCL, you can see that you can achieve a much better stability of the posteromedial part of the elbow. You see here in the video, just by pulling on this ligament. Now you have to address the coronoid. As I told you, you need to be ready for everything. And also, if you are not able to fix you need to have an external fixator in the OR. In this patient, we were able to use a dedicated coronoid plate. Remember that you have to repair both the MCL, the posterior part of the MCL, and the anterior part of the MCL. And now we prefer to use two different small anchors for the anterior bundle and the posterior bundle. And then remember to address the LCL. I think that addressing the LCL, it's important, not just for the stability of the elbow, but also to protect the fixation of the coronoid, because you know, sometimes it's very comminuted, so it's very difficult to have a very stable fixation. So if you repair strongly the LCL, you will unload your fixation of the coronoid. That was our postoperative protocols for this man. And he had a quite, I'm sorry, I don't have the X-ray. I thought I put the X-ray on the presentation, sorry. Oh no, you see here, there is the X-ray. You see a lot of metalware to fix the coronoid, also some free pins, and two anchors, two small anchors for the MCL, and one bigger anchors for the LCL. This is the X-ray at 3 months. And this is the patient with a quite good range of motion at 3 months. And so far is doing very well. So, Shawn, any additional remarks from you? Any other comments?
Beautiful, beautiful case, Davide. And I think you touched on everything that one needs to understand about these. For many years, I didn't repair the posterior bundle of the MCL because I recognized it as not an isometric structure, so I didn't know how I would repair it. I changed plans about that when I did one of these arthroscopically, and I could see vividly where it needed to go back with an anchor. And from that point forward, I've repaired them. And it really makes a difference if you do. So I agree with you that repairing all three structures is important. I would just emphasize that the most important thing is to recognize this entity. So anytime you see an apparently isolated coronoid fracture, you should instantly say to yourself that that's probably an anteromedial fracture from a posteromedial rotatory injury. And you must do a CT scan. You must confirm that the joint is not incongruent, or these will become arthritic rapidly. And it's the only situation in elbow that I treat directly by a total elbow when they failed their initial treatment. So if one of you in your age group came to me, wrote to me an email, said it's really bad, my brother, my sister, or me personally, I had this posteromedial rotatory injury. It was thought to be not a big deal. I was in a sling or whatever for a while. Now it's 8 months later and my joint is arthritic and stiff and it's painful. Then I'm going to actually tell you that how I'm going to treat you is with a total elbow arthroplasty. And I don't do that for any other condition. Rheumatoid, fractures in rheumatoid elbows, distal humerus fractures gone bad, etc. It's just that these are generally not salvageable once they become arthritic. So don't miss this injury. With time, we'll clarify which need to be operated and which can be treated non-operatively. And then finally, I would just mention that the preferred treatment will evolve as well. Currently, I treat these arthroscopically, and I think that that's a very good way to do it, but that would not be within the skill set for most surgeons, of course. So open treatment is the standard of care still. Great case.
Thank you, Shawn. Natalia, should we move to Shawn cases, or shall we go through the questions? Maybe we can comment on the question after Shawn presentations. What do you think? Natalia, you are mute.
You're muted, Natalia.
Yes, sorry. I said that Dr. Risco should start because we have half an hour, so maybe he can present his case and the questions at the end.
Okay, very good. All right, are you seeing my PowerPoint now? Yes, are you able to see my PowerPoint?
Yes.
Great, wonderful. Well, greetings, everyone. This is my first time doing this, so it's a new experience probably for all of us, or most of us anyway. And I've decided what I'll talk about is unrecognized posterolateral rotatory instability. In the process, I'll make sure we cover the basics of PLRI as well. And I'll take this from the approach of two completely different types of cases in order to cover it. So I have disclosures that are not relevant to this particular topic, but I thought I better put that in there nevertheless. Well, let's start with this patient here. This is a 49-year-old female bodybuilder with a long-standing history of lateral elbow pain, failed conservative treatment, has not had any injections. On examination is tender at the ECRB origin, has a positive tennis elbow shear test, positive laptop test, equivocal posterolateral rotatory drawer, and negative lateral pivot shift tests. So, Nick, what are you thinking when you see a patient such as this?
I would ask her if she had any trauma in her past history, see if she had any other elbow injuries, at what level she's performing bodybuilding, or what her expectations of treatment will be.
Right.
Should I comment on the MRI picture as well? Or
yeah, we'll get there momentarily.
Oh, okay.
Certainly, we'll do that. But yes, I agree. She's had no trauma. She has a lot of different sites of tendonitis. She is a competitive bodybuilder at a very, very serious level. She's not professional, but her life revolves around this and has for quite some time. If you saw her, you would realize that, yeah, she's obviously a bodybuilder. So, Pierre, are you thinking anything in particular based on that MRI right there and the clinical presentation? Are you thinking anything in particular? Is this a straightforward tennis elbow, or what are you thinking?
We can see that there is a clear hypersignal in the lateral collateral ligaments in the deepest parts, at least 50%, I think. On the part on the radial head is not injured. I think it's rather on the humeral side of the ligament. So according to the clinical presentation, I think there is instability, almost only showing on the sign of pain rather than the instability itself. So I think it's the best hypothesis. Yes.
Yeah. So Pierre, if I understand you correctly, you're thinking that there is a form of instability, or at least there's a spectrum of instability within which, at the minor end, they might present only with pain and not realize that the elbow is unstable. Am I understanding you correctly?
At my level, yes, I think so.
Yes, I agree with that. Anyone else have any comment on that entity? Is that something that the panelists recognized or think sounds kind of fishy, or what are your thoughts?
And what about patients with laxity? So I'm thinking about a patient of mine, and she has developed kind of clinical case like yours, Dr. Driscoll, but she has hyperlaxity symptoms as well, but she's always complaining about lateral pain. And I didn't have the chance to take her to the OR because that are my plans, to test her under anesthesia and see how the elbow develops. But I was thinking that she has also developed some subtle instability, because she told me about 2 minor trauma, but I was concerning about her hyperlaxity as well too. Yeah.
Right. Yeah. So I think it's relevant to always check the other side and compare them. So somebody who does not have, this patient, for example, does not have hyperlaxity, but we see patients who do. If they don't have hyperlaxity, then what you're looking for is asymmetry between the two sides. And in her case, it was quite, I shouldn't say quite asymmetrical. It was moderately asymmetrical. Most times it's rather obvious. This was obvious, but not quite to the point of being dramatic. I'm just going to scan through this MRI. This is an MRI of a 49-year-old female bodybuilder This particular cut is taken midway between the anterior and posterior margins of the radial head. And we can see that the ECRB origin is detached from bone, that is quite pathological. As we go further anteriorly, of course, we continue to see that. And then as we go posteriorly, we see that, first of all, the ligament is very lax. And as we go further posteriorly, that's even perhaps more obvious. So what appears to be tissue at the origin of the LCL, or partial detachment, is in fact a very significant structural alteration to the ligament. And this patient has significant posterolateral rotatory instability in addition to the tennis elbow. So I did mention that her posterolateral rotatory drawer test was equivocal. That means in my mind, I can't decide whether this is clearly a positive or a negative test. The lateral pivot shift test was negative. And by the way, it usually is in the tennis elbow patients, usually, but not always. So what's the sensitivity? What's your sense about the sensitivity of clinical exams, all the maneuvers altogether, for picking up posterolateral rotatory instability compared to, say, an EUA? Like, is it worth doing an EUA on this person? Sebastian, what are your thoughts? Might an EUA reveal something that the clinical exam here does not?
I think it might be worth a shot, because in my experience, the clinical examination of PLRI is very, very difficult. And I agree that sometimes you're not very sure about if you actually do detect the instability or not, just from your examination. And also, I sometimes feel like, because often those patients do have this epicondylitis-like pain, they also don't really tolerate the testing itself. So I think whatever you can do additionally to detect the instability should, in this case, be done.
Yeah, I would agree with that. I think most surgeons would say that they're a little unsure just how confident they can be in their clinical assessment for instability. So if you can get that experience and that confidence, that's great. If you cannot, then certainly you need to be aware that this might be an unrecognized case of PLRI. In a study that we did, my own sensitivity in the clinic compared to an EUA is 94%. So I'm confident about that, but I do know that once in a while I miss it. And so that's when I would call it equivocal. And so we did go ahead and do an EUA on her, and you'll see that this is actually— So we have the arm in the overhead position. The posterolateral rotatory drawer test is positive. You can see the dimple forming and the bump right there as the radial head goes out with the ulna and goes back in. You can see that actually there's an actual click or a clunk, maybe you'd say, as well. The lateral pivot shift test is just barely positive, it's almost, no, it'd be borderline. It doesn't quite go enough to pivot fully out and then to reduce with a clunk. So posterolateral rotatory drawer test positive, lateral pivot shift test borderline, and so I'd have to call it negative. So that's the typical scenario in tennis elbow, is that the lateral pivot shift test is not positive. Hers was, almost there, as borderline. Wasn't positive though. And that's just due to the fact that the total magnitude of the instability is fairly mild compared to a patient with traumatic PLRI. So did have positive PLRI test and did have a reconstruction, as well as tennis elbow debridement, did extremely well. Well, Anna, this is another kind of masquerading case, an unrecognized PLRI. This is a 15-year-old boy with a history of having had a supracondylar fracture at age 5. He presented with about 1.5 years or so of chronic pain at the lateral epicondyle, 20-degree cubitus varus deformity, and was diagnosed with tennis elbow, and was referred for a question of whether or not he should have treatment for tennis elbow. Do you see anything wrong with this scenario? What are your thoughts?
Oh, wow, that's an impressive case. Well, in the picture, we can see how this kid hyperextend his elbow. And this kind of, I don't know, because I'm thinking that at the top of the elbow, I think that's the olecranon, but I'm not pretty sure.
Oh, yeah. So that's actually, yeah. This is actually the lateral side of the elbow. So he doesn't
Yeah.
hyperextend, but sometimes they do for sure. That's the prominence that you see on the lateral condyle over here on the right side of the screen. So this is an AP of his humerus and kind of a lateral of his foot.
Yeah, yeah.
So it's close to an AP of his elbow itself.
Yeah. And in the X-rays, we can see that the medial elbow is kind of underdeveloped because I cannot see a proper trochlea because he's 15. It should be like a properly developed trochlea, almost full developed. And obviously, because he didn't have a trochlea, then the olecranon is not developed as well, as we can see here on the lateral view. Right. So yeah, so she's got a varus deformity, and to me that stretches the lateral side of the elbow. That can cause his pain there. That's what I was thinking. Yeah.
Right, exactly. And so he does have dysplasia, and that's typical in these patients with cubitus varus. When it occurs early in childhood, they end up with a dysplastic distal humerus and a dysplastic ulna, very, very dysplastic in this case. I have a saying, and I think if you were to write something down today, it'd be worth writing this down because it is the most valuable thing that I think I can teach people. The saying is that when it seems like something's not right, it's usually because something's not right. Now that might sound silly or funny. It's not meant for humor. It's meant to trigger some thinking in the mind that we often find ourselves seeing a situation and thinking, something's not right or something's fishy here or something seems wrong. And we don't get past that. We don't recognize what it is. Well, the something that's not right here is that this is a 15-year-old boy with tennis elbow. I don't think tennis elbow occurs in 15-year-old boys. I don't believe it occurs. I realize that sounds a little bit strong. What I mean to say is that I suspect that you don't get the pathology of tennis elbow as early as that in life. And so the pain is probably related to something other than actual tennis elbow. And as Anna says, it's probably related to the stretched out lateral soft tissue complex. So we've
what's heating up, and he can feel it. He can feel like a crunch. There's a crunch.
Here's his exam,
and I'm just moving the radius forward like that. Well, not towards me, but that way. So just out towards you. Okay.
So his exam is subtle there. But on EUA, where he doesn't guard, so this is it's a little bit more
posterolateral rotatory drawer test. You can see the radial head, and there's the capitellum moving out and plunking back in. You can see that. You can see it's actually fairly dull. I can do it with one finger, like there, one finger. You see, it's not forceful. And if I move my hands further back, you can see the clunking a bit more obvious. If I put a valgus load, there's more clunk. If I put a valgus load, you see enough of it, it stays out. Why? See? Look, I can push it out and back in.
So that's his posterolateral rotatory drawer test. His lateral pivot shift test was also negative, and the lateral pivot shift test, which was the test that I originally described for this condition, is only positive, assuming a person can do it. It's not a problem of the exam itself. It's only positive if the magnitude of the instability is beyond a certain threshold. And we've learned over the years that, just as I think Pierre said, that there's a spectrum, and in the lower end of the spectrum, just like with shoulder dislocation versus subluxation, there's a portion of the spectrum in which the elbow does not subluxate far enough to actually get a lateral pivot shift test. And in some patients, it doesn't go far enough for them to even know that it's subluxating. And so a really important feature to be aware of. And this, of course, is treated by osteotomy of the distal humerus and then ligament reconstruction. These patients also have routinely a subluxating medial triceps and dislocating ulnar nerve. And so we either excise or transpose laterally that medial cord of the triceps and transpose the ulnar nerve. If they have no pain whatsoever in the medial side of the elbow, it may be that you don't have to do that. Very often they do have pain there from that being irritated. And we've published about this. I would recommend that you look this article up. We published 21 years ago about it. This was a multi-center international report, which took about 3 years to gather all the data. Rob Spinner, who is now the chair of neurosurgery at Mayo Clinic here and did his orthopedic residency as well as his neurosurgery residency, really did the bulk of the work of getting all this data. And these were 25 elbows in 24 patients. Osteotomies were not done in everybody, but when the threshold of about 15 degrees of cubitus varus was reached, that was generally when it was done. And so we have this sense that a varus deformity of about 15 degrees, or maybe a net varus of 20 or a bit over 20, is probably a reasonable indication for osteotomy as well as the ligament reconstruction. And they do well if you do that. If you fail to recognize the deformity and its cause for the instability, they'll fail typically. And there are two reasons that these become unstable. So you already mentioned, Anna, about the stretching out on the lateral side. And that's what I would refer to as the passive mechanism in tardy posterolateral rotatory instability. So you see that on the left over here, the normal side of this schematic, the elbow is in valgus. And so when you bear a load on it, the load is distributed across the elbow in a way as to not stress the lateral soft tissues. Whereas when it's in varus, the lateral soft tissues are being stretched out, and so they're attenuated. Patrick, is this a condition that you're already familiar with? Not everybody is.
As in post-traumatic deformity in adolescence, yeah.
Leading to a delayed onset or tardy posterolateral rotatory instability, which, by the way, usually doesn't come on until their 30s or so. That's something.
Sorry, I personally have not seen it, but I have seen deformity, but I haven't seen it in later life.
So the reason I ask is that I think that most people who are early enough in their careers that they've not heard about it, I don't mean have seen it, but haven't heard about it yet, like you guys are hearing about it today, those who don't already know about it. Most people are completely unaware and not suspicious at all that this exists. So for example, that patient that I showed you, the 15-year-old, that was a patient in Ethiopia. And a friend of mine who's a missionary surgeon there, he's been there for a couple of decades, wrote to me before I came, and he asked me about this curious case. And I said, oh, he probably has tardy posterolateral rotatory instability. But I've never seen it before in anybody who didn't have mechanical symptoms and a dislocation from that. But let me examine him when I come over. And sure enough, it was positive. I subsequently started wondering if maybe it's more common. And so I've routinely been examining people with cubitus varus. And it's shocking to me how common unrecognized PLRI is in their elbows. I now have 4 patients, had no idea they had PLRI. And, but it was only picked up because I just examined their elbow. And so the point is that it's out there and we're not recognizing it. Certainly I used to miss it. Well, there's also an active mechanism in this condition. And the active mechanism, these are from the paper, is due to the dysplasia that Anna pointed out. The dysplasia of the trochlea and of the medial olecranon are such that the pull of the triceps, instead of being a net valgus producer in the elbow or a net external rotator of the ulna, becomes a net external rotator, becomes a net internal rotator of the ulna. So the medial olecranon is prominent and elongated. So the triceps starts to rotate the olecranon this way. The triceps is offset from the center of rotation. So that has a torsional vector on the ulna as well. And we were able to prove this in 3 of the patients we reported. We stimulated the triceps with a TENS unit intraoperatively while preventing extension of the elbow, and documented that the triceps actively subluxated the elbow. So watch that picture right there. We're going to now look at a patient, flip that picture around that you just saw, and now look at this picture and this elbow. And remember what I said about the mechanism here with the torsion on the ulna. I flipped that one upside down too. And imagine this drawing being his elbow. And now watch the video. So I've outlined the ulna with a very dysplastic, elongated medial olecranon. The medial epicondyle is over here, lateral epicondyle, the radial head. And you can see that with this elongated medial olecranon, the triceps is going to have a predominantly medial pull. So try to straighten your elbow. As I prevent his elbow from straightening by holding the wrist, his elbow rotates off in posterolateral rotation. Relax. Do that again. Straighten your elbow. Relax. Do it again. Relax. So you can see it's as if his triceps is over here pulling on the ulna to rotate the whole forearm. Try that one more time. And then relax.
And you can see one last time there. Okay, relax. How it subluxates off, virtually dislocates. And if he has a valgus load on it, go ahead and push it out. Now, if there's a little bit of a valgus load, relax. See, it doesn't go back in. Now, if I relax the valgus load, it'll gently slip back in. I'm gonna let it pop back in there. There you go. So I did not recognize this very clearly at all for a period of time. The very first patient I operated on with this condition, I told him that probably the deformity is relevant to the instability, but I didn't really know for sure. And so I did a ligament reconstruction and he failed that. And he told me that in the cast, he felt like his elbow was dislocating. So I redid it and he told me again that in the cast, he felt like his elbow was dislocating or coming out of joint is what he said, actually didn't say dislocate. And I wondered if maybe he was a little bit crazy or something. But sure enough, he failed his second operation. And I sent him to other surgeons. I even sent him to a surgeon who thinks very differently than I do to get a different way of thinking about it. I asked Dr. On, our biomechanics lab director, to think about the mechanics and help me through this, and eventually came to the conclusion that it must be the deformity. And then I did his osteotomy and ligament reconstruction, then he succeeded. And it was only years later that I came to realize that some of these people are actively subluxating the elbow. And now that I know to look for it, it's something that's much more recognizable than when I first started treating these patients. So it is a complex problem. And just to kind of put that in perspective overall, it's a little bit like a positive feedback wheel. And so what happens is that they start with cubitus varus. This creates an abnormal biomechanical axis and an abnormal triceps vector, which then results in chronic medial overpull and increased stress on the LCL, which leads to the attenuation that was referred to by Anna. And then suddenly at some point they have an injury and they dislocate or subluxate. But no, I'll come back to the but in a second. And now that they have injured the tissues, this now becomes a positive feedback and it gets worse and worse and worse. What I didn't recognize when we published this illustration is how long the period of time might be between this LCL attenuation and the first mechanical event that they have. So I've just presented you with a 15-year-old who had had no mechanical event. He had no idea the elbow was unstable. And this is that early phase that I think probably goes on for a couple of decades in most of the patients before they actually have an event, then they dislocate, and now they have recurrent instability. So just to be aware of that, that'll get reported more and more in the future, I imagine. And as we talked about, the reconstruction is a valgus osteotomy, reconstruct or imbricate the LCL. There are options both ways, and do something with the medial triceps, either transpose it laterally or excise it. But I transpose it laterally when it's a predominant cord like that. I have a video I can show you later of the reconstruction if you want, but I didn't want to go into that now. So the key points then are that tennis elbow with, you should suspect unrecognized PLRI when you have tennis elbow with multiple injections. The patient I showed is the only patient I have ever had who had no injections. Everybody else has had multiple injections. A patient with failed tennis elbow surgery should be suspected. Patients with cubitus varus, and anybody who's had a dislocation as a child because they have dysplasia after they've had that dislocation. And so they may end up with this problem of unrecognized PLRI. But just before we go to open the discussion, I should mention to this group, because of your interest, about a Teach the Teachers course that we have. You can see that email down on the bottom right there. You can email there if you're interested in it. It'll be both online and in person this year. And the topic will be the unstable elbow. So you might want to be looking into that if you're interested. Thank you very much. So discussions, questions?
Shawn, I have a question for you regarding your first case. Would you consider the option to repair and not just to reconstruct the LCL? Because at MRI, I mean, the LCL was not like a disaster. It seemed to me that there were some fibers very, very close to the lateral epicondyle. Why not just to try with an anchor and try to repair, not to, because the surgery is much easier and probably also a faster rehabilitation.
Right, right. So Davide, that's a great question. I've proposed to my partners that we try to develop a multi-center randomized controlled trial to do just that, to compare those. I think it's a really great question. There are enough patients out there that if we had a randomized trial, we'd be able to answer that. I don't know that we would have enough on our own to do that. So maybe between yourself and myself and everybody else involved, we might actually get started doing that at some point in the near future. I don't know the answer. I can share with you how I got to the decision to reconstruct instead. I had a patient with both medial and lateral tennis elbow, so to speak, who had markedly positive posterolateral rotatory instability on the lateral side. And so I did a reconstruction on the lateral side, and on the medial side, I did a debridement repair, I call it. Now, this patient had Ehlers-Danlos, and she assured me that she would need a Tommy John operation on the medial side as well. And I told her that since she was not unstable on the medial side, she did not need a ligament reconstruction, just a tennis elbow operation. But she assured me from multiple other surgeries that that would fail. And interestingly, it did fail. And so I did a Tommy John, and she got a perfect result from it. And I thought, well, that's pretty strange. I don't really understand that. But for the next few patients who presented with tennis elbow and instability, I told them this story about this patient and said that we could do a reconstruction. And I started doing reconstructions and was kind of amazed at how well they did and how quickly they improved. They got free of their pain. I then decided that maybe the patient who has instability and tendonitis has more problems getting over the tendonitis because the joint is loose, and that maybe we should stabilize the joint in order that the tennis elbow can settle down. And so I've generally recommended that to them subsequently and been very, very pleased with the outcomes. So that's a long answer. I apologize for it being long. I don't have the answer. I would never suggest to somebody that you should do a reconstruction instead of a repair. But I would be open-minded to the possibility of either outcome being possible, a worse result or an equivalent result. And if we can show equivalence, or you're not concerned about it perhaps not being as good, then a repair makes perfect sense. How are you treating them, Davide?
Usually, I'm agree with you. I go for reconstruction. But to be honest, also, I treated a couple of patients with a repair with an anchors, and they went very well as well. So again, I don't have the answer. But what I normally do, I use a 5.5 metallic anchor with some matrix suture. You can do a very strong repair in the majority of these patients. My only concern are the patient after multiple corticosteroid injection, because sometimes the tissue is not, the quality of the tissue is not good. So in that patient, I prefer to reconstruct.
Yeah.
To repair.
I have a question. When you're doing a reconstruction of the LCL, are you still doing the classical technique described by Dr. Mori, or are you currently doing more modern techniques with more available approach, or what are your preferences right now?
So in the original technique that I described, it's a very slight modification of the original technique. In the original technique, we passed the graft right through the humerus and out the back and wrapped around the humerus. We no longer do that. We dock it into the humerus and only put sutures around the humeral supracondylar ridge. The second modification is that in the original technique, I added a reinforcement stitch that I called a temporary ligament. It would now be thought of as an internal joint stabilizer if it was made out of metal, but it was a PDS double-stranded suture that went from one tunnel in the ulna to the tunnel in the humerus through the soft tissues in an arch, just as a stabilizer, but I no longer add that as well. So it's pretty similar with a slight modification, a little bit smaller operation. Oh, one more difference. We exposed a fair amount of the lateral condyle in the early operations. I don't expose any of it now any more than just a split to get to the origin of where the ligament should be placed in order to not detach anything that is still stabilizing the elbow.
Okay, thank you.
You're welcome, Anna.
Dear all, thank you for the great time and great cases and great discussion. I hope you all enjoy it. And thank you, Dr. Driscoll and Davide, for your time, and Natalia and SECEC for organizing this wonderful meeting. And see you next time in 3 months, because we unfortunately got to the end of this wonderful meeting. Thank you very much for your time.
Thanks, Joanna. I see that there are some questions that didn't get a chance to get answered. If there's a way that we can answer those and send the answers out, we'd be happy to do so.
We'll coordinate with that with Natalia.
Okay. Great.
Thank you very much.
Thanks for
Bye.
organizing.
Thank you very much.
Thank you.
Okay.
Thank you.
Sebastian,
Thank you.
Patrick,
Thank you. Bye.
Bye.
thanks, Natalia and Joanna and Sylvie.
Thank you, Dr. Driscoll. Thank you, Davide. Thank you, all of you.
Very welcome.